Good evening, everyone. So I would be presenting a case of atypical myeloproliferative neoplasm. Dr. Namrata has made my presentation a bit more easier. I mean, it's a similar sort of case, I would say. So this patient presented to us with high TLC. There was an history of persistent splenomegaly and leukocytosis with since 1 month. The peripheral blood picture showed a leukoerythroblastic picture with mild left shift, 2% blast, 3% basophils, and was suggestive of MPN. With this picture in presentation, we just did a FISH for BCR ABL, which was negative. A karyotype was also attempted, which was 46XY, all the 20 chromosomes showing 46XY, so it was normal. Patient had a past history. He has a long-standing past history of around 8 years, wherein he had a persistent splenomegaly. His counts were normal. There was a mild increase in peripheral blood previously. No molecular tests were done. Patient was advised to keep on follow-up and was managed conservatively. With this peripheral blood presentation, past history in mind, with FISH for BCR ABL been negative, the patient was advised by our clinicians to go ahead with bone marrow studies and an NGS comprehensive panel. Bone marrow was done. Bone marrow was cellular. The aspirate showed increase in megakaryocytes with hyperlobated forms. No clustering was seen. Bone marrow biopsy was interesting. It was hypercellular. Streaming was noted. Fibrosis was noted. Megakaryocytic hyperplasia. Bizarre forms of megakaryocytes were seen. The reticulin stain showed a grade 3 fibrosis with focal collagen fibrosis. We did a comprehensive myeloid gene panel. It's basically an oncomine myeloid gene panel that we perform. It has DNA and RNA sequencing both. So we utilize the peripheral blood at presentation because it was ordered simultaneously, and then the bone marrow was also done. So DNA sequencing showed a frame shift insertion mutation in exon 9 of CALR gene, which is very commonly known as type 2 variant of CALR. The VAF was of around 45%. This is an IGV picture of the CALR mutation. Interestingly, the RNA sequencing gave us a BCR ABL fusion. However, the fusion reads were just 51. We have a cutoff of 250 reads. If the reads are more than 250, then only we call a fusion positive. But there was something that was seen. Since it was BCR ABL, we have multiple assays at our setup to do test BCR ABL. We did an RQ-PCR. RQ-PCR showed a mean copy of 629 BCR ABL with ratio of 0.76 and IS value of 0.53. A DDPCR was also done, and it also was concordant with what was shown by RQ-PCR for BCR ABL, 0.7% BCR ABL ratio. RQ-PCR was attempted on bone marrow also because we wanted to confirm whether it is truly present in bone marrow also. We did the RQ-PCR on bone marrow and it showed a ratio of 0.9 with IS value of 0.66. Patient followed up after 1 week of the marrow, and we took the peripheral blood and we performed a DDPCR. DDPCR again showed a small clone of 0.89% of BCR ABL. So to summarize, persistent splenomegaly since a long time, PBS suggestive of MPN, bone marrow suggestive of primary myelofibrosis, NGS showing CALR type 2 variant with a small clone on BCR ABL. Now, this clone was not false positive. It was confirmed by 3 orthogonal platforms. So what was the diagnosis? Whether it was a myeloproliferative neoplasm with PMF with CALR type 2 variant, but what about the small clone? Whether it was CHIP or it was a small clone that was present within an MPN. So whether it was a CALR positive MPN with PMF and a small clone of BCR ABL. We stayed over there. Clinician went ahead a step. He asked if BCR ABL is present, should we start the patient of TKI? We never had an answer for this. What does literature say about BCR-ABL? Can BCR-ABL occur in normal healthy individuals? Yes, it can occur. 1995 first paper was published and it mentioned a case showing BCR-ABL in normal healthy individuals. Normal healthy individuals can have BCR-ABL which can be less than 1%. The level of BCR-ABL in true normal population harboring BCR-ABL and pre-CP warrants further study. So if there is a small proportion of BCR-ABL present, you need to keep the patient on follow-up. That is what we did. We kept the patient on follow-up. Patient was started on hydroxyurea meanwhile, and the decision for TKI therapy was postponed till follow-up was done. We followed up the patient at 5 months. We saw that there was an increase in BCR-ABL ratio. Whether this increase was true or it was relatively because the WBC count had gone down, we were not really sure. What does WHO mention? It mentions that primary myelofibrosis very rarely can acquire BCR-ABL gene rearrangement. However, the clinical significance of this is uncertain. Due to this additional phenotypic mutation, a morphological hematological shift capable of producing CML-like evolution may occur. There is very recently in 2020 article published mentioning atypical myeloproliferative neoplasm with concurrent BCR-ABL and CALR fusion, wherein the authors have documented 13 cases, which presented like PMF or ET with CALR and a concurrent BCR-ABL. Some of them had a BCR-ABL diagnosed as CML priorly. Some had a BCR-ABL CML development later on. Starkingly, the description of the morphology that has been given in the paper matches what was there in our case. Patients presented with splenomegaly, leukocytosis, and large clusters megakaryocytes with grade 2 to 4 fibrosis. So, to summarize, this is a rare case of concurrent CALR type 2 variant with BCR-ABL gene rearrangement. We have yet called it as atypical myeloproliferative neoplasm with concurrent CALR and BCR-ABL fusion. Patient has been continued on hydroxyurea therapy. We have advised a follow-up for quantification of both CALR type 2 variant as well as BCR-ABL fusion. Thank you.